focused on localized prostate cancer, advances in treatment. It's obviously a huge spectrum, and we only have time to touch on a few pieces of that. But again, there are a lot of clinicians here that you can ask questions about. So our first speaker in this next session is Dr. Dan Lin, who's an internationally recognized urologist focusing on the prevention and treatment of prostate cancer with a particular interest in this idea of active surveillance. So, Dan?
Perfect, thanks. Well, thanks, Pete, and it's really nice to see everybody here today. This is our fourth annual conference here, and I'm just happy to see everybody come out for this. So, as Pete said, I treat patients along the spectrum of prostate cancer, so that might be patients that have higher risk prostate cancer. I do robotic prostatectomy as well as open and other urologic malignancies. And then what we're going to focus on this morning is early, very early prostate cancer. So again, amongst the whole spectrum of prostate cancer, this is prostate cancer that we've traditionally thought of as the turtle on the block, and I think that's not my nomenclature, but probably attributed mostly to Paul Lang in this setting, is the turtle on the block cancer that might never harm a patient. And so, again, out of all the prostate cancer we diagnosed in the year 2015, that might be as many as half the cancers are these turtles on the block that might never need to be treated. And of course, there's a whole other half, if not more, of the prostate cancers that we do feel benefit from treatment. So this first part of this session will be focused on the slower ones, the sort of the snails or the turtles that we see that we diagnose. And we do something called prostate cancer active surveillance, and I think that I presented this before in past years. We clearly know that the safety of active surveillance is established. There are now worldwide guidelines that place active surveillance as a standard of care option, as just one option. And I'll show you that in a coming slide. And the question is who to do this on. So I said the turtle on the block, which is an easy image of a little turtle barely creeping along. And we call this low-risk prostate cancer. So this would be the low-risk group by various different groups, or maybe even very low risk. And what does that really mean? I'll show you that on the next slide. And maybe even prostate cancers that seem to be maybe a little bit more aggressive. So who are the low-risk prostate cancers? Well, typically this is who they are. For those of you in the room, you might recognize the stage just as what we examine with our digital exam. A PSA of less than 10 and a low Gleason score. These are the turtles that we think the low-risk group of prostate cancer. But then there are the very low risk, and you can see here listed on the slide. I won't go through all of them. There are various similar aspects. This is PSA density. This is how many cores from the biopsy might have cancer and so forth. We think this is very low risk. And is it really very low risk? Well, these are the sort of the blunt criteria. And I'll show you, Dr. Chang showed you the NCCN guidelines. That's the National Comprehensive Cancer Network. We're one of this network, so all the major cancer centers. We're the only NCI-designated cancer center in the Northwest for the many-state region. And we all sit on a committee called the NCCN Committee. And the NCCN puts out guidelines for all different varieties of malignancies every year, and this is the one that just came out in 2015. So this is the NCCN Cancer Guidelines, and they say very low risk here. You can see many different criteria. I would say that some of us don't even calculate PSA density. Many take less than the number of cores, and they put this in this group. But if you look here, and I could walk you through the next two slides, this is expected patient survival. So if a man is expected to live more than 20 years or 10 to 20 years, you can see for very low risk, down here it might say do active surveillance. Whereas up here, a longer life expectancy, really it's balanced between active surveillance, radiation, or surgery. I think that, again, this very low-risk criteria is not really followed by many, so what the NCCN did was just lump it all together and say, just low risk. You just have, if you just qualify based on these criteria over here, low risk right here, which most, at least half of the prostate cancer that I'll diagnose this year is low-risk prostate cancer, probably 50%. Maybe not quite 50. But when you look here, a man, and most men fall in this greater than 10-year life expectancy. What really surprises me still is that we lump the initial therapies into one of three choices. and they're all equal. There's not one that's really superior recommended over the other. One is active surveillance, which we'll talk about. The other is radiation or prostatectomy, and active surveillance involves biopsies, and you can see here they say get a PSA, repeat a biopsy about once a year, maybe not quite once a year. But then you have this balanced against radical therapies, and we know that these radical therapies do have side effects, which we can't get into for sake of time. And what's amazing to me is that, and Dr. Gore showed this a little bit, these are all balanced options, so they're equal. There's not one that the NCCN is recommending over the other, but clearly 80% or more, perhaps 90% are choosing the radical therapies. And is that reasonable or not? We'll get into some of that right now, actually. There are major questions, and I'll spend about 2 minutes on each of these major questions and then end, and we can do question and answer. But are these criteria for entry accurate? Are biopsies really necessary? Biopsies, as Dr. Gore was saying, have risks. A corollary to that are there alternative methods to determine whether we should have a man on active surveillance? And the last big one is, can we alter prostate cancer behavior even after the diagnosis for the turtles on the block? And we'll get into just one slide of that as well. And it really plays in to the strengths in the first session with Dr. Newhouser at Stanford and others, showing what they do and whether we can really affect prostate cancer behavior. To do this, I'll show results from one of our trials, the trial that I lead and we lead here at the Fred Hutch. It started as somewhat of a West Coast effort funded by a foundation called the Canary Foundation based in the Bay Area. And then over time, it's really spread across the nation as 9 different sites with central pathology. And we have about 1,200 patients that are enrolled in this prostate cancer active surveillance trial, where men that choose active surveillance are entered into this trial, and the big focus of this is biomarkers, and here's how it works. If they have prostate cancer diagnosis, they choose active surveillance, they have serial exams, serial biopsies, we collect all sorts of specimens. If there's something we call pathologic reclassification, which means that they seemingly have a little bit worse prostate cancer, some of them choose to get primary treatment, some of them choose just to continue active surveillance, even if the cancer looks like it's getting worse. If there's no pathologic reclassification, many still get primary treatment, others choose to continue, and then of course we have long-term follow-up. We're all about biomarkers. Pointing this slide as we get blood, serum, urine, DNA on all our patients, and are following them quite extensively. And I'm filling up freezers here at the Fred Hutch at a frightening rate, and drawing the ire of the administrators. But you see here we're getting a lot of specimens. We're going to make some great discoveries, I think. I really do think we're on the cusp of many great discoveries, and I'll show you that in a minute. When one looks at all the different sites we have, they're all fed in the Fred Hutch here, and then we collaborate with third parties as well as industry. We have a very big pipeline with industry, and I think that's very important to align public and NIH dollars with industry dollars and really make some progress. So what does it mean to be progression on active surveillance? Well, we really consider it to be just something in the biopsy. Any increase in the tumor grade, so it goes from that Gleason 6 to a Gleason 7. Maybe there's 1 core out of 12 goes to 3 or 4 or 5 cores. That's really what we consider progression. Now, others talk about maybe something like a digital rectal examination being worse, or maybe even PSA going up. We really collect that data, but we don't use it because it hasn't really been proven to be of great benefit after the diagnosis for these particular patients. And I'll just show you just 1 or 2 slides. This is where we are currently, again, almost 1,200 patients. We follow them for about 3 years. We're still getting them, so there are some patients that have been on for 6, 7, 8 years, but we have a median of about 3 years. About a third of them have been reclassified. In other words, their cancer looks a little worse. About 250 have had treatment. So again, not all men that the prostate cancer looks a little worse are actually going on to treatment. And of these 250, some of them actually have worse cancer. And I think as opposed to, I had all these flow charts in here, but I think as opposed to doing that, let's just cut to the chase. If you take 100 men and they're the turtle on the block, and we follow them all, and we say we're going to do biopsies every year or 2 and get your PSAs, all the blue ones are going to still stay in active surveillance after 3 years. Their cancer does not appear any worse, and or if it does, they say, I just want active surveillance. The ones that are in red are getting treated, and the ones there that are unfortunately in the dark figures, they're treated and they actually do look like they have pretty aggressive pathology. But if you really look at that, that's 100 people, and there are 6 of them that seemingly could have, and they've never had recurrence. None of them have died of prostate cancer. Nobody in our 1,200 men have died of prostate cancer. And again, these are select groups, so these are the group of men that we think are the turtles on the block. But this gives you an idea of the safety of active surveillance. But can we do better? And I think that this gets to the next is, can we do better? Well, we can. We actually just published this month in European Urology, where we have a risk calculator and one can plug in, and again, I won't do the whole exercise, but many men come to me and say, do I need the biopsy? Do we really need the biopsy? And here is a calculator where we can plug in the age, the month since the last biopsy, what their PSA is, how many cores were positive, how many positive biopsies, and so forth. And it can just spit out a pie chart, and it will say, the chances of a man having progression or increased grade of cancers, in this case 14%. The risk of no cancer on the biopsy, like the biopsy finds no cancer, is right here is 41%. That doesn't mean the man doesn't have cancer. That means that it was just missed by the biopsy. And then there's about a 45% chance of having the same Gleason 6 disease. And you can see here, does this man need a biopsy? Well, that's in the eye of the physician and the patient. So we have actually a biopsy risk calculator now. We've also, as I said, aligned with industry, and we're looking at new biomarkers. And one of them is this biomarker called Prolaris. You might have heard about it. It's based on the biopsy tissue. It's something called cell cycle. And they've had many different publications showing that this biomarker, if you do it on tissue, predicts prostate cancer death or recurrent prostate cancer. It helps decision making. And I'll show you how that works. And again, not to get too much in the weeds, but I want you to focus over here. This down here, just focus down here. This is the chance of recurrence. Okay, so what we're really talking about are these guys. That after treatment, the chance of recurrence is probably only 10 or 15%, which is pretty good. That means 90% or 85% of the time they're cured, we think, by just what we know about their Gleason grade, about them, about their age. But if we use this test, you can see, so we know that their risk of recurrence is somewhere in 10 to 15%. But if we use this test, we can actually find the dot that they are. And we could actually say, well, it looks like you're 10%, but if we do this test, you could be 30% chance. So this test does stratify this much different than this much. And I think that it's an interesting test, and we're using this one quite a bit. There's another test called Oncotype DX. You might have heard about this. They have a breast cancer test. They're based in the Bay Area. This is a similar, you send the tissue, they look at the genes. So we look at it under the microscope and we see Gleason grade. They look at it under the DNA microscope and see different genes that are up and down. And their endpoint is different. Their endpoint is whether if you took a man's prostate out, he'd actually have bad prostate cancer. And again, I'll show you a very similar representation. Just focus down here. Actually, focus over here first. Focusing over here, if you look at these guys here, let me just go back. If you look at these two little dots here, I can say to a man, based on clinical values, that his chance of having bad pathology is somewhere between 10 to 15%, right here, these two dots. But if I do this test, I can really put them along this line, and I can say that as opposed to just being somewhere around 10 or 15%, I can really stratify you amongst this whole line. So I think it's a very important test. The last one that we're looking at is something called 4K score. The 4K score is 4 different calicities. Now, PSA is one of them. It's been used as an algorithm. I'll show you that in the next slide. It really improves the diagnosis of prostate cancer. So we use this in men that have had negative biopsies maybe, and it is appearing to be very useful. And what it does is this. It takes your various circulating calicities, and one of them is PSA. So total PSA measures all these little products here. There's PSA, there's something called NIC PSA, Pro PSA, HK2, complex PSA. And what it does is it combines them all into an algorithm, all these 4 calicities. It adds in additional clinical information, and then it spits out a score, and that score is really associated with high-risk disease, high-grade disease. And so we're using this along with others. So it is my belief that we have a blunt instrument. We say, you have prostate cancer, you can have active surveillance, which is basically nothing, or radical treatment. And again, I find it very surprising to say that I show this slide to my patients all the time. They say, Dr. Lin, what do you think I should do for my prostate cancer? And I say, this is what the nation and the world thinks you should do. Let's go through why one is better than the other or not. I think that hopefully at one of these days, and this is 2015, mind you, that we're going to get to 2018 and we are going to have some sort of a biomarker score. That's the hope. The low biomarker score, you stay on active surveillance. If it's medium, you have a choice. If it's a high biomarker score, you go on for radical therapy. And I think that we're working that way. I put here 2018. I'm very hopeful that it's earlier. But right now, I think that's a pretty conservative estimate that we won't get there until then, at least with our work. So the last couple of minutes, I want to talk about future studies, and this plays into a little bit of what you heard before. I think that we're very, very involved, certainly in the biomarkers and what you can find in the blood or DNA, and we've worked with Dr. Stanford and others who have a great platform and infrastructure for doing these studies. And we're interested in other things. How about lifestyle dietary modifications? How about hormonal manipulations? How about complementary medications? And of course, if we can do these in the men that are on active surveillance, and then you repeat biopsies, imaging, other molecular diagnostics, we're really going to find, I think, some insight in the disease behavior, of course, looking at all the tissue and blood. And I will put a plug in. I think Dr. Newhouser mentioned this before. This is an NIH-funded study that we're very proud of one of our young investigators, Jonathan Wright, having, and again, men with active surveillance that might have a slightly higher BMI, the body mass index. And they will be randomized to either a healthy lifestyle intervention, it's part of a diabetes prevention program if there's exercise and nutrition, versus basically just standard recommendations, as opposed to a very intensive lifestyle change. And then there's various endpoints, and we, I think, are going to find some ways to manipulate the behavior of prostate cancer in this way. This is just, again, a little bit of a plug for what we are doing. This, grant funding is really the currency of research, I think. At least one of them, the federal dollars, of course, we rely on philanthropic efforts quite a bit, but these are some of the federal dollars which we've received for various efforts. And again, I think that you'll hear about this later. We're into the precision medicine approach and a personalized approach to prostate cancer. So the take-home points for you, and I think that entry criteria for active surveillance are generally well established. There's a high rate of adherence in our group. There are these emerging biomarkers in industry which we find very promising. We have many potential interventions, some of them being diet and lifestyle. And then I think the overarching challenge really is to find out which cancers are indolent, which cancers are aggressive, and lower the burden of what we call overtreatment, while also identifying men who actually need treatment right away. So I'll end here and just put my past team. Thank you.